Hello, welcome to this presentation entitled Preparing for the Future, Where You Live Matters, Aging in Place with an Ostomy. My name is Jeanine Gleba, and I'm the Advocacy Manager at United Ostomy Associations of America, also known as UOAA. I've been with the organization for several years leading the advocacy program. Joining me today is Sue Mueller, a retired registered nurse and wound ostomy continence nurse who also lives with an ostomy. She currently serves as co-chair with me on the advocacy committee, along with Joanna Burgess-Stocks as the other co-chair. Sue has been volunteering with UOAA for many years. We're going to help you understand the factors that determine your care and where you can receive it as an ostomate. By the end of this presentation, it should be clear that people living with an ostomy should be welcomed and treated as any person seeking potential residence in an assisted living facility and not forced into a facility with a higher level of care. Attendees will have the tools they need to self-advocate for living in this type of facility. For the purposes of this presentation, we will be using the acronym ALF as an abbreviation for assisted living facility. This could become a mouthful after a while saying that, so bear with us with our acronym. For those who need closed captions, we have enabled this feature, so please turn it on so that you can see the live transcript. So what does aging in place mean? According to seniorliving.com, aging in place is when a person lives and ages in their residence of choice for as long as they are able to. Aging in place includes having services, care, and needed support in the residence as well. These needs may change over time and as the person ages. Some topics to consider when aging in place are things like costs, safety, and housing adaptations, such as a grab bar in the shower. This presentation, however, is not designed to be a comprehensive guide to aging in place. For that information, we highly recommend you visit the National Institute on Aging website. Now we'll get started with the actual presentation, and I'll turn it over to Sue.
Hi. We first wanted to share some stories that sparked the interest of the Advocacy Committee to look at aging with an ostomy. Why? Because in each instance, the ostomate was not able to access the care they needed because either the healthcare system or care providers did not understand the needs of the ostomate. People with ostomies were either barred from admission or their retention in a facility was threatened. In one case, the person was recommended to remain at a level of care that was more restrictive than he needed. Many healthcare authorities believe that if a person receives the right care at the right place, at the right time, the outcomes will be better. Well, that is what the UOAA Advocacy Committee is trying to promote. We want ostomates to receive the right care in the right place at the right time. What we saw with this first example is an assisted living facility employee who essentially closed the door to an ostomate for admission because of a belief in the myth that ostomies equal leaks and extra staff would be needed for his care. In this next story, home care was ordered for ostomy management education, but after the nurse worked with this ostomate, she discovered that the problem was not a knowledge deficit, but a memory problem. This patient was unable to use any reminder systems. She needed someone to assist her with managing her medications, and she also needed help managing her ostomy care. She was able to stay in her apartment because her care plan was amended to include reminders to empty her pouch regularly. In this circumstance, the answer for help changing her appliance was for her daughter to come in on a regular schedule to assist with appliance change. In the next story, I was a part of the ASG team who advocated for this gentleman with the nursing home. He had gone from the hospital to an acute rehab hospital and finally to a nursing home to receive therapy. He had fallen and broken his bones in his neck. He was very dizzy and was not thinking clearly. He was unable to self-advocate. The nursing home did not recognize how vital it is for someone with an ileostomy to maintain hydration and electrolyte balance. Once he was properly hydrated and his electrolyte balance was restored, he began to improve and was able to resume his own ostomy care. He was successfully able to return to his apartment and did not have to accept the verdict of the skilled nursing facility, who just saw him as a long-term care candidate. In the next situation, we heard about a couple who was separated, but we do not know the outcome. We wonder how many others are in this circumstance who don't know how to stand up and speak out. In the last story, the ostomate's family reached out to UOAA. They were surprised to run into a problem securing the ideal assisted living apartment for their mother because their mother's ostomy had never been an issue. The solution for them was finding another facility that approached ostomy care very differently. The new facility had a tiered care program so that they were able to purchase the specific care they needed. That facility was prepared to provide care to meet their residents' needs. They were familiar with ostomy management. So sometimes the answer is persistence and flexibility.
So our national efforts. What have we learned? In our research, we've learned that assisted living facilities are regulated at the individual state level, not federally like skilled nursing facilities. And each state has unique regulations which vary widely from detailed regulations to very general regulations. Assisted living facilities also come in many shapes and forms, from very large facilities to small family homes. There's no universal language or definitions among the states, and there's a great deal of variance in the services provided. Many states declare what must be included, and most states let the facilities decide what they will offer for services. Many services are based on what the ALF staff can handle and if they have the proper training to provide the care. Other services are amenities like transportation to shopping and social activities. Fortunately, some states have built waiver and exception policies into their regulations so that people may advocate for their needs and have more participation in their plans of care. Probably the most important thing we've learned is that all states are very clear that facilities can refuse admission to anyone whose needs cannot be met by the facility. We've learned that there's a lot of confusion about what ostomy care consists of, when you need a healthcare provider and when you don't. Many states only name colostomy in the regulations with no recognition of ileostomy or urostomy. And we notice no mention of continent diversions either. Belief in ostomy myths and the stigma surrounding people with ostomies is common. In our research, it appears that some states restrict ostomy admission, including Connecticut, Delaware, New Mexico, Nevada, Georgia, South Carolina, Massachusetts, and New Hampshire. But some of these, such as Nevada, will allow ostomates if the resident can perform self-care or hire a medical professional to provide the care. Some states like Virginia and California don't specifically mention excluding ostomy. However, it gives the flexibility for the facility to not admit or retain anyone for any service they don't provide. So basically, if a facility doesn't want to provide ostomy care, they don't have to. States that we've encountered issues with have shared some of their reasons for not accepting or retaining people with an ostomy, and they include myths like people with an ostomy have an odor, ostomy pouches frequently leak, an ostomy is a wound and requires a sterile procedure for care. Changing an ostomy pouch is an invasive procedure. Emptying or changing an ostomy pouch requires continuous nursing care or skilled care. So what have we done? For the past few years, we've had an active advocacy effort on this issue, and we've done several things. We've brought the issue to the attention of the WOCN Society, and they've become an active partner in this effort. Together, we've developed a fact sheet, which we're going to discuss more later. We also contacted the National Ombudsman, also known as the Consumer Voice Organization. After several attempts, they responded with the recommendation that we should reach out to the assisted living national associations and ask for their help in educating their members. As a result, we contacted the National Center for Assisted Living, that's the NCAL, which is part of the American Healthcare Association. The NCAL recommended that we submit an education proposal to their convention. We did this, and unfortunately, our proposal was not accepted. After exploring their websites and finding the state associations, we just decided to send our facts to each state association. We sent a joint cover letter with the facts from both UOAA and the WOCN Society to all state associations for assisted living facilities. We were very happy to receive responses from 8 states: Arizona, Indiana, Maine, New York, Pennsylvania, Utah, Minnesota, and New Hampshire. And the majority shared it with their ALF members. Some states did even more, like including it in their newsletter and also meeting with us. We gave a webinar to the Pennsylvania members. In these outreach efforts, we learned some good news that many are not aware of any issues with admitting and retaining people with ostomies. However, some facilities might be apprehensive, maybe even fearful of ostomy care, and that with education and awareness, we can make them more comfortable. The vice president of the Pennsylvania Healthcare Association who was also very aware and knowledgeable about ostomy, said that it probably isn't so much a concern with changing or emptying pouches or even cleaning the stoma area. He believes they're probably more concerned with skin assessment to identify infections or complications and not having the properly trained staff to do it. He thinks many facilities don't realize that they can bring in a certified home health agency to do staff training or the skin assessment. So this was important for us to learn so that when we do go out and educate and raise awareness with facilities, we make them understand that they can bring in a certified home health agency to either do the staff training or help with the actual skin assessment. So to give you a better idea of an assisted living facility regulation, this is an example from Nevada that specifically mentions people with an ostomy. I'm going to give the audience a few seconds to read it over. Take note of the language where they mention colostomy and ileostomy, and that, they must not be admitted or retained unless they're able to do one of those two things. They also call on the caregivers employed by the facility that they ensure that, all pouches used by the resident are discarded appropriately and that privacy is afforded to the resident when care is being provided. So how does the healthcare system in the United States define needs? The following slides are definitions from the Centers for Medicare and Medicaid Services. CMS is the federal agency that oversees long-term care facilities. And as you can see, they define skilled care as a type of healthcare given when skilled nursing or rehabilitation staff is needed to manage, observe, and evaluate care. So any service that can be safely done by a non-medical person or by the person themselves without the supervision of a nurse isn't considered skilled care. The definition for custodial care, which is also known as unskilled care or personal care, that's things like help with activities of daily living, such as bathing and dressing. And these things can be done safely and reasonably without professional skills or training. So the bottom line is whether your needs are skilled or unskilled, determine your level of care and where you receive that care. This last definition is actually taken from the actual regulation that CMS has, and they specifically say personal care services do not require the skills of qualified medical professionals. And they actually call out that an example of a personal care service includes, but is not limited to, general maintenance care of colostomy and ileostomy. So this was a really good find for us in our research, so that in our facts and when we do educate facilities, we can specifically show them in black and white that CMS does not consider general maintenance care of a colostomy and ileostomy skilled care. And therefore, again, there's no reason why an assisted living facility can't provide ostomy management care.
Okay, hi. So what do you need, skilled care or unskilled care? What constitutes ostomy care? We were not able to find any reference that broke down ostomy care into its components, so we created this checklist. Some of the components require physically performed activities, some planning and more complex thinking tasks, but we think it does a good job capturing what constitutes ostomy care, and it's not just emptying a pouch. Problem solving includes how to treat a simple skin issue, and additionally, knowing when you need to get medical help with a skin issue. Lifestyle management includes managing hydration and electrolyte imbalance and avoiding foods that may cause blockage. The checklist can be used by an ostomate or to help caregivers or family to understand ostomy care. It can also be used by healthcare professionals to assess ostomy self-management and to design a care plan. This checklist is now available on the UOAA website. None of us has a crystal ball that shows our future. We don't know what our needs will be next year or in 5 years. Needs can change suddenly or more slowly. A new ostomy is often the result of a sudden change, like a ruptured diverticulum or a tumor. People have been hospitalized for an overwhelming infection and leave with an ostomy. Slow changes that impact your ability to manage your ostomy could be caused by the visual changes of macular degeneration or the impairment of mobility caused by arthritis or Parkinson's disease? What if you can physically perform your care, but forget how to hook up your nighttime drainage bag or remember to drink enough? The reverse could also be the case, when you can direct all your care but not perform it or need assistance to perform it. What if the change is not in you, but in the caregiver you depend on, who can step in to help? Right now, think about it. Who besides you in your family or support system knows how to perform your ostomy care? Okay, you know there are skilled needs and unskilled needs. If you have skilled needs, you require a different level of care than if you have unskilled needs. Ostomy care can include both skilled and unskilled care. Here are some examples. Care for a new ostomist is skilled care because it involves teaching ostomy self-care skills. Teaching must be performed by a medical professional. Teaching a new ostomist is then covered by insurance in the hospital and in facilities and at home by home care. If an ostomist has a peristomal skin problem and requires nursing assessment and treatment, the care is skilled. Daily ostomy management, like emptying a pouch, is considered non-skilled care and is an activity of daily living like toileting assistance. Managing supply ordering is considered an instrumental activity of daily living and is non-skilled care. Where is healthcare provided? I know this is a lot of information, but if you can understand these concepts of how the healthcare system works, it will be so much easier for you to navigate and self-advocate. The information on this slide should probably be its own slideshow, and I'm condensing it to one slide, so please stay with me. Remember I mentioned the right care in the right place at the right time? The right care means care that matches your needs. The right place is the right level of health care. The right time is when you need it. Level of care is about the right place. Acute care is hospital level of care. Subacute care is less than hospital level. An easier way to look at this is to compare care in an intensive care unit versus care on a surgical floor. You don't want to be in an intensive care unit if you don't need it. You would rather be on the surgical unit. The surgical unit is less restrictive than the intensive care unit. You have more freedom on the surgical floor. Visiting hours are more liberal. You have more privacy. The intensive care unit is the right place when you need more attention, when the freedom of visiting and privacy is secondary. This is why we object to people going to long-term care because of ostomy care before they need to. In that case, they are not in the right place for the care they need. They could be in a less restrictive environment and receive the personal care assistance they need. So the hospital, the long-term acute care hospital, and the rehabilitation hospital are all hospital level of care. The hospital is for a short stay. The long-term acute care hospital is for a longer duration of stay. For the rehabilitation hospital, you need to meet rehabilitation criteria. Next is the nursing home. This is where you go when you have the need for skilled care, but not hospital level of care, and you can stay longer. But what gets confusing is that nursing homes can have two levels of care, the skilled care level and the long-term care level. Medicare and healthcare insurance pay for nursing home care at the skilled level because they pay for skilled care. At the long-term care level, you receive custodial care, which is unskilled care and is also known as personal care. Medicare and insurance do not pay for this level of care. The last place on this list of places to receive skilled care is at home from a certified home health agency. Basic ostomy care is unskilled, personal, custodial care. So if you need this kind of care only, you would not go to the hospital, the long-term care acute hospital, the rehabilitation hospital, the skilled care section of a nursing home, or receive home health care. So where would you go? Some people have family members or support systems who are willing to provide this care at home. You could also privately hire a nurse or a personal care aide to provide care at your home, or you could find an assisted living facility that provides personal care assistance. This is where assisted living facilities fit in. An ALF can often be a bridge between healthcare facilities and long-term care.
So again, where does assisted living fit? This quote comes from the American Healthcare Association, the National Center for Assisted Living, whom we contacted in our advocacy efforts. Assisted living communities serve individuals who typically need help with everyday activities, but do not require 24-hour skilled nursing services for an extended period of time. It should also be noted that ALFs can be freestanding or part of continuing care retirement communities or life plan communities. These communities usually combine independent, assisted living, memory care, and skilled care in one location. Not all offer all levels. And they also have different types of contracts, and some have entrance fees and some have monthly fees, and these can increase with the level of care. An important thing to remember and keep in mind is that as an assisted living facility is considered your home, and therefore, again, you may receive certified home health care at that location. So like we mentioned earlier, we've partnered with the WOCN Society, and together we've created a fact sheet for assisted living facilities to dispel the myths that we've learned about and provide education about the needs of people with ostomies. It offers answers to questions such as, is an ostomy a wound? No. Does emptying or changing an ostomy pouch require continuous nursing care or skilled care? We hope after the previous slides, everyone can recognize that no, it does not. When does ostomy care require skilled nursing care? Sue talked a little bit about this, and on the fact sheet, we go into greater detail, but an example of when you would require skilled care is for that initial education and the first pouch fitting, or even when you need, as your needs change, you might need to be reevaluated and change your pouching system. Another question we delve into is, when should an ostomy seek medical attention? And for sure, there are certain times when you should be calling a doctor or seeing a certified ostomy care nurse. And those are for things such as severe cramps lasting more than 2 or 3 hours, a deep cut in the stoma, excessive bleeding from the stoma opening. So for all of the frequently asked questions and the complete answers, we highly recommend that you print out the resource. It is now available on both UOAA's website and the WOCN Society website.
So these are the points we hope will stay with you. The majority of ostomy care is personal care, an activity of daily living, or an instrumental activity of daily living. We want to remove the veil of mystery that has surrounded ostomy care and say what it is: simple personal care. I hope you can now see that identifying your care needs is the essential first step in the process of how to get your needs met. You are the expert on you. Do not expect someone else to decide what you need. Participate. Be an active participant in your care. That doesn't mean don't collaborate. You bring your expertise about you to the table. The other people at the table might bring their expertise about the facility or financing or community resources. Then you put it together and make a plan.
Now we're going to get into some tips on how to prepare for the future. And I'm just going to let the audience read them, and I'll do a little talking. So ultimately, choosing a place is a very personal choice. I think everyone will agree that, some people like groups and lots of social activities, while others prefer their comfort zone in their own home. UOAA is not in the business of how to find care facilities or which are the best ranked facilities or things to look for when considering. Anyone can find these types of resources, and there are lots of wonderful articles on this online. We highly recommend that you print out the ALF fact sheets by the National Consumer Voice for quality long-term care. Additionally, Medicare.gov is another great resource, and they have the ability for people to put in their zip code and find and compare nursing homes, hospitals, and other providers near you. Additionally, when you explain your medical conditions and needs with the facility, especially when you're talking about your ostomy needs, please share the facts to self-advocate. And that's another thing we just want to bring home, is that it's not, when you're looking at these facilities and researching them and determining your needs, it's not just your ostomy needs. You might have other underlying medical conditions that you might need to factor into what type of facility can provide all of the care that you need. And, we highly recommend that, you read reviews, see what other people are saying about the place, see how CMS ranks some of these places. CMS does not rate assisted living facilities because they do not provide funding for those things. And also they don't oversee them like they do the skilled nursing facilities. So this slide just contains just a few tips that you can do to help prepare for the future. Again, I'll let everyone read these things while we do a little talking. But planning ahead clearly is key. Don't start looking when you need it. Do the research now before you need it, so that if there comes a time when you need a higher level of care, you're prepared. But also say you have a say in where you live before someone has to make that decision for you. It's always good to have a plan B, and please make your wishes known to your loved ones also. This slide just scratches the surface of some of the things to consider and questions to ask. But for example, visit the facility, have some meals there. I know from personal experience with my own parents that, the dining facility and the food they serve can make a big difference in a person's happiness. So just little things like that can make a big difference. Again, consider, how well you're walking. And if, right now you might be walking great, but again, your needs might change, and your distance from your room to the dining room, you might not be able to walk that distance. So there are definitely lots of things to consider. And final thoughts, we hope after the presentation that you realize and recognize that ostomates should be welcomed and treated as any potential assisted living resident. They shouldn't be separated from their partners or spouses. There's, again, if you're fine with your own self-management, there's no reason for you to be forced into a higher level of care. UOAA also can't specifically address each state's issues. It's too varied across the country. So education remains the best course of action. And now we have the proper resources when someone contacts us with issues. We encourage you to use the resources we have provided to get the answers you need. You need to self-advocate again, that you don't be put into a skilled nursing facility if you don't need that level of care. Additionally, please be aware that UOAA does not do additional one-on-one advocacy for every person in the community, nor do we maintain a list of assisted living facilities that do accept and retain people with an ostomy. This type of list would change constantly anyway, and we just don't have the manpower resources to manage such a list. But on a final note, we do know of some states such as Arizona, Florida, Maryland, Minnesota, and Pennsylvania that do admit and retain people with an ostomy. Once again, the bottom line is that all the states are very clear that all facilities can refuse admission to anyone whose needs cannot be met by the facility. And when you think about it, that kind of does make sense. There's, you'd hate to go to a place and you do need care, and the place is not able to provide that care. That just would become another big issue. So having that kind of regulation does make sense. But again, you have to do your research and make sure that they do have the care that you need. So like many of our advocacy efforts, change will not happen overnight, but together we can make small improvements when the need arises. Our last slide is going to focus on some of the resources that we now have. And Sue will close out for us.
So what to do with these resources? First off, print the first 4. The checklist will help you identify your needs and help you to explain what makes up your ostomy care. The ALF fact sheet can be your cheat sheet for answering questions about ostomies when you talk with facilities. Give a copy to the ALF, to the facility when you speak to them, so they can increase their understanding of ostomy care. And always have a copy of the Patient Bill of Rights at your fingertips. These website resources will lead you to fact sheets to help you select a facility, give you steps for getting quality care, and how to problem solve when you are in an ALF. Other resources give you more details about types of assisted living facilities, about contracts and care arrangements. There is also information on aging in place and community resources. At Medicare.gov is where you look for the Nursing Home Compare. And that will give you one way of looking at each nursing home. Remember, you want to get the right care in the right place at the right time. Thanks for joining us.